Welcome to How Do We Improve Communication and Collaboration in Return to Work? Dr. Fergal O'Hagan is currently a senior lecturer in the Department of Psychology at Trent University in Peterborough, Ontario. He completed a Ph.D. at the University of Toronto and postdoctoral training focusing on work disability prevention. Before and during his doctoral training, Dr. O'Hagan practiced in the field of occupational rehabilitation, holding progressive positions in public and private sector organizations. He has worked with a range of clinical populations developing, managing, and evaluating occupational rehabilitation programs. His research examines individual adaptation to chronic health conditions with a specific focus on work functioning. He is a registered kinesiologist with the College of Kinesiologists of Ontario, consultant to LifeMark Health on occupational rehabilitation issues. Without further ado, I will hand it over to you, Fergal. Thank you for being here.
I think there are two main take-home messages from this session. One would be that communication and collaboration occur across a complex network of stakeholders with varying interests and agendas, situated in different systems and through a range of media. And this poses challenges for our ability to work together on these cases. And secondly, that improving communication and collaboration will require an integration of stakeholder systems through media, but also the recognition that we have a shared sort of purpose and need to undertake effort together to resolve work disability issues. That includes taking the perspectives of others involved and integrating our approaches to determine a return to work fit. So colleagues of mine developed this model a number of years ago that describes the systems involved and in the return to work situation and their interactions, and they likened it to an arena because of the sometimes contentious nature of work disability. So in the arena, you have the worker with a work disability in the center, and surrounding the worker, you have a personal system, a workplace system, a healthcare system, and an insurance system. And each of the systems plays a role in either maintaining or reducing work disability. So the personal system is the system of the worker, and that includes the worker's physical status, their thought and emotional response to illness, and immediate social relations with families and friends. The workplace system includes the worker's job position and its various qualities, such as physical demands, the immediate relationships the worker has with coworkers and supervisors, qualities of the organization responding to work disability, and aspects of the external environment, such as economic conditions that might affect the labor market and prospects of the organization. The healthcare system, so this is involved in providing medical and rehabilitation support to the disabled worker, and includes the worker's attending physician and allied health providers involved in the worker's immediate treatment and potentially multidisciplinary and interdisciplinary teams involved in care. And then lastly, the legislative and insurance system. So this includes the immediate claims adjudicator and manager and other insurance personnel such as caseworkers, and the legal framework that bounds the system. So problems with, not surprisingly, problems with communication and collaboration have been identified by all stakeholders, so workers, employers, and healthcare providers. And on the part of workers, what we hear is physicians not spending adequate time and understanding their work situation, employers not respecting limitations that are put forward in functional abilities forms, and workers also talk about the onus placed on them to act as a go-between on top of the health issues and financial stress that they're experiencing. So kind of pulling this together, what are some of the factors influencing communication and collaboration? Well, I think we see complexity of workers' health condition being a significant one, particularly where you have psychological and pain conditions that are not necessarily objectively measurable. They create, a lot of questioning and a certain amount of distrust within people involved in the system. Or a worker with multiple needs, such as the individual who got into the car accident and also had a cancer diagnosis to deal with. Knowledge of and attitude towards disability management. So this is both on the part of physicians and employers. So physicians, for example, there are still physicians that really, question the value of early, safe return to work. There are employers who question the value of and requirement for accommodation. The nature and location of return to work assessment. So, by its nature, doing a return to work assessment in a physician's office cannot but be based on subjective report. If you go to a physio clinic with a gym, there's a lot more opportunity to observe the motor functions of the patient and make a determination on, and spend more concentrated time with them, and come to a more, let's say, objective determination. Healthcare provider knowledge of work and workplace policies and practices. Like physicians, and they'll tell you this, they're not they're experts in diagnosis, prognosis, and treatment. They're not experts on work and workplace policies and practices. And some of the physicians that we've talked to would prefer that judgments around functional ability determinations be offloaded to OTs, PTs, or kinesiologists who have greater expertise in the areas. Healthcare practitioner practice economics. So here, the healthcare practice, efficiency is a primary concern in the healthcare practice, and remuneration is an issue for all the healthcare practitioners that I've spoken to, and making return to work recommendations. And then varying expectations regarding return to work timing among workers, employers, and healthcare providers. Workers, they still tend to view return to work, for some of them, shouldn't happen until they're fully recovered. Employers feel that as soon as an individual is able to undertake anything that could be accommodated, they should be back in the workplace. So what makes for good communication? Well, we think that really there are two things. One is the utility or usability, or the what of the information that is provided. And the information provided should be able to inform accommodation, adjudication decisions. It should enable other stakeholders to do their jobs. So information provided by healthcare providers should be adequate to enable employers, provided that they're equipped to do so, to identify ways and means that they can accommodate the worker in the workplace. And communication should also promote and maintain positive relationships among stakeholders during the return to work process. And then secondly, there's sort of a how around accommodation, around information. So stakeholders involved, it needs to be effective in that the stakeholders involved need to view information, the information that's been developed and provided, as credible because of a proper procedure. And that gets at issues around dictation and the subjective nature of information development that takes place in physician offices, for example. Information should be provided in an efficient way. So it should be competent, well organized, and economical. Information should be provided with consistency according to procedural and legal requirements. So, for example, requirements laid out in legislation like PHIPA or that kind of thing around sharing health information. Communication should take place in a way that helps people to work together. So an example that I am experienced with in a clinical setting is when injured workers sort of operating in their interest might help or might attempt to split a treatment team by sort of setting them off against each other, causing them to question each other in terms of their handling of the patient. And then personal congruence. So communication should be, in some way promoting the interests of the stakeholder themselves. So some of the root causes of communication and collaboration problems. Here, I think one thing is where, who, and how return to work decisions are made, and the situated nature of reasoning. So as I've alluded to, even if a physician were expert in determining functional abilities, coming into an exam room, having a patient sitting in front of them, asking them questions, maybe getting them up, maybe having them get up to touch their toes, do a squat or something like that, doesn't provide the kind of information that's needed in order to process and make good determinations around functional abilities. So that's one of the issues that I think is important. The media used to communicate return to work information. So forms and guidelines here, and this gets at the old idea, the medium being the message. So if you look at a return to work form, it's got tick boxes for lifting this and sitting and standing, but we know that with problematic return to work cases, the issues relate to psychosocial barriers and impediments. And it's rare that I see those kinds of things addressed in the communication media that we use, and I think that that's a problem. Knowledge and ideas around how return to work decisions are and should be made. So employers, in the research that I've done, talk incessantly about the need for objective information. And I agree that the closer we can get to something that really identifies the underlying capacities of the individual, the better. But I think it's unrealistic to have that perspective in the day-to-day practice that occurs in physicians' offices. And I think that we need to come to some, we need to be sort of settled in our ideas around this and realize the constraints that exist that do not permit objective information to be obtained at every step of the way. The common good versus individual interest. So as I mentioned at the outset, individuals, everybody is coming into the situation with a selfish interest, a portion of selfish interest, a portion of altruistic interest, and a portion of collectivist interest. And the more we can sort of enable the altruist and collectivist interests to emerge in the situation, the better. And lastly, sort of relating to perspective taking, assuming the motivations and actions of others are negatively motivated. It's not, when a physician is sitting down with a patient, it's not in the back of their mind, I don't think, that they want to, make things hard for an employer here. But they're sitting in front of an individual who's, crying or pouring out their life story to them, and all the difficulties and all of the badness of their work. And they have to make a decision in that interest that's going to be in part a very rational decision and going to be part emotionally driven. So how do we improve communication and collaboration? Well, I think that we need to have communication tools that integrate the needs of various stakeholders. So for example, in using, let's say, an electronic media tool, providing voice for the worker, having guidelines for employers and insurers, and help, well, voice for workers guidelines for employers and insurers that healthcare providers can use, and enabling features that allow people to identify psychosocial barriers that are going to be going to get in the way of return to work. Secondly, enabling perspective taking on the part of stakeholders through embedded information, education, and direct communication where possible. So where we can share information about the varying perspectives that people have, either sort of implicitly in a form or more explicitly through educating them and enabling some direct communication. Number three, be practical in acknowledging the limitations in assessment and determination of return to work function. And here, my grandmother used to say, you can't make a silk purse out of a sow's ear. You cannot, with present technology, you cannot make a physician's office a place where you're going to get really reliable, objectively determined information about physical function. And some conditions, such as mental health conditions, just you can't enable that, full stop. Acknowledging the social dilemmas and interests on the part of different stakeholders in the return to work process. So, as is possible, identify shared interests and avoid position taking when negotiating a return to work. And I think in terms of assessments, using the right person at the right place at the right time to make return to work assessments when they're needed. And here I would suggest that, if a physical medicine practice, for example, is a more ideal place to make return to work assessment determinations than, a 12 by 12 physician's office, or at least giving information that will contribute to determination of return to work.